Hello, everyone. We're just seeing as everybody piles in. We've had a very good response, so we hope we're going to get up to our normal mark, getting near the 200 mark this evening. But a very warm welcome. You've seen what the subject matter, AI in public health, how has AI helped us cope with COVID-19, and this really should be an extremely interesting session covering the full range of different aspects of AI in healthcare during the COVID crisis. And we've got a very broad range of panelists today taking us through very different aspects of the use of artificial intelligence, because obviously there are huge numbers of lessons we can learn from the use of both AI and the data during the course of the pandemic, and of course to see whether or not we have accelerated the use of AI. A lot of people talk about it, but has it really done that, or is that just simply going to happen anyway, as originally planned in terms of medicine discovery and so on? First of all, an apology from my co-conspirator, Stephen Metcalfe. I co-chair. He is chairing another gathering at exactly the same time, so sends his apologies. So I'm both going to be kind of moderating, but also asking some questions as we go along. And then we're going to throw it open probably in the last half an hour. We'll try and have as much time as possible to open up after our panelists. And so please do put your Q&As in the Q&A box, and then we'll select out of those and ask some questions as we go along. But so let's start, I think, with very appropriately with the director of AI at NHSX, who have been so heavily involved throughout the pandemic, Dr. Indra Joshi. Indra.
Brilliant, thank you, and hello everyone. As said, I'm Indra Joshi. I'm the director of AI. I oversee a program called the NHS AI Lab, and my background is as an emergency medic. I was an A&E doctor for many years in the past. So today I'd just like to very briefly give an overview of how the work we've done with multiple partners during the pandemic has really helped in public health, how we really do advocate for the hashtag data saves lives, but also the potential for AI to make a difference both in health and care across the UK. So just to give a very brief overview of some of the work, during the early stages of the pandemic, we in NHSX worked really closely with NHS England's data and analytics team to essentially organise what we call operational data. So very early on, we were relying very heavily on localities and regions to inform us of bed status, ICU numbers, etc., and oxygen capacity. Very rapidly, we set up something called a data store, a COVID-19 data store, which enabled all those operational issues to be put into one place. And that enabled decision makers, both regionally, nationally, but also at a government level, to really understand the pandemic and the picture. And that is still being used today. And on the back of that, we also published the public-facing dashboard as seen on the gov.uk site. Now, what's the importance? Where does the AI come into this? So that's collecting data. So data is of vital importance. But the thing we've done on the back of that is also build some forecasting tools to enable the projected spread of the disease. And that's been done with partnership with both NHS England, but a number of other key players. And these are still being used to help localities and regions really understand where that spread is. So that's a real tangible use case of how we've used both data and then modeling techniques on the top of that to really help in the pandemic. Another few examples are we have built something called a COVID-19 chest image data store. Very early on in the pandemic, we had a number of companies and industry players come to say to us, look, we can really help you both understand the pathology of the disease, but also how it can spread. And so we've partnered with a number of institutions, BSTI, for example, which really to collate images to help us both understand how that disease is being affected within the human body, but also to help researchers understand both identification of it and the spread of it more rapidly. And that's still being used today, and it's still there. It's on an open source site as well on our website. And so just to sort of conclude, I can carry on and give lots of many examples of where AI and data has been very helpful during the pandemic. And there are a lot of opportunities, but we've got to be really mindful that AI is not a silver bullet. It's not going to fix all of our problems. And we've got to focus as well on getting some of the fundamentals right. So we've got to focus on the digital transformation of health and care services, ensuring the workforce is both competent and capable of using these technologies, but also ensuring we maintain public trust in these technologies as we move forward. And some of the programs we've established in the NHS AI Lab, working with our regulatory partners, working with institutions like the Health Foundation, the Wellcome Trust and Health Education England, to really bring together some of those fundamentals, is a key take-home message I would like to leave people with. So we're really trying to take the right steps. We've got a long way to go, but the closing remarks will be, we mustn't forget those fundamentals and the governance of this as well. Thank you.
Thank you very much indeed, Indra. I'm just going to ask each of our panelists a question as we go through, just to sort of be a bit provocative. I mean, Indra, you've talked about the really positive side of the data collection and analysis that NHSX has been doing. And of course, you are the spearhead, within the NHS of, if you like, all things tech. As you were designed to be. But there must be a communications issue in a sense, isn't it? Because the good news message has not come out from NHSX in quite the way that, say, for instance, the message about the COVID app came out. And isn't that unfortunate in a way? Is there a sort of rebalancing that we need to do in order to make sure that we actually get the message about the trustworthy AI, the use of the data in a really positive way, rather than the kind of, stop-start on the COVID app?
That's a very valid point. And I would say more broadly, what we've really pushed, and very much with localities, regions, trusts themselves, and with a number of kind of important stakeholders, is to say, this is what we're doing. We've been transparent and published a number of documents on our website to say, this is the work we're doing. And I would say in terms of communications, during a pandemic, there are always pressures, both operationally and on the front line. And so we've tried as much as possible to try and send out positive messages and address, where appropriate, negative messaging or miscommunications, should I say.
Yes, I'm with you. But more work to be done by the sound of it. Yeah. Thank you. And now on to Dr. Keith Grimes, Director of Clinical Innovation, Babylon Health.
Well, hello everyone. My name is Dr. Keith Grimes. I'm an NHS GP and I'm the Clinical Digital Health and Innovation Director at Babylon Health. Just very briefly, Babylon, for those that don't know, is a London-based company with global reach, doing two basic things. We do digital-first primary care. So you may have heard of GP at Hand. We have about 95,000 patients served mostly within the London area with that, as well as our operations globally. And we also produce a number of AI-powered self-care tools. So those are things such as the symptom checker, which helps people when they supply information to understand more about what they might need to do and gives them general advice about what some of the causes for their symptoms might be. For health check, we allow them to enter information so we can find out more about their modifiable and non-modifiable risk factors so they can make decisions about how they can reduce their risk of disease going forward. And then with Monitor, we can help track symptoms and some of the measurements so they can better manage their health. But the reason that I give that background and what I want to talk about is what we've learned from the deployment of different types of AI technologies through the course of the pandemic. And the reason I'm doing that is because it was a really big focus of our work during COVID-19, because we had these products and services out helping patients, but we had to adapt them to meet the new challenges. So you'll probably recall at the start, around about a year ago today, when things were beginning to kick off, there was an awful lot of uncertainty. The disease was new, the defining symptoms weren't clear, and in particular, the best treatment options were being established. So I suppose from an AI point of view, some of the foundational ground truths weren't entirely clear. And it was also not entirely clear what to do when a person was unwell, whether you stay at home or seek help or get tested. So we had that situation with unstable information, but also that how that information that got shared out was very, very variable. And I think people talked about an infodemic at the start. There was the infection, but there was also a lot of variable information. So we, like all other providers, you know, within the NHS and without it, really wanted to do something to help our patients come to the right decisions. So what we did is we tried to find the best available evidence to update the symptom checker. The idea was that then people could use that to identify whether they had symptoms that were consistent with COVID or not. It's something that actually might seem a little bit odd now because we've been with this for a year. You know, a lot of people have got this ingrained into them. But even so, we need to identify the sickest people that might need care, but also, you know, help those people care for themselves. We had to build this in a way that complied with safety and also regulatory standards, but also was in lockstep with what the UK government was saying, but not only just the UK government, in any of the territories that we operated as well. So you can begin to sense that there was quite a deal of complexity that we had to deal with in just getting the source information before we could then train the machines to help with some of the work. Now, whilst it reflects some of the difficulties we're facing, I'm going to make some recommendations, if I may, about how we might, if hopefully we don't have to face this too soon, but if we get faced with similar public health or large emergencies again, how the information is provided outside some of the open data that Dr. Joshi was talking about a moment ago, about how we approach these problems, that would be very helpful. Anyway, we're able to respond very quickly. We were serving about 2,000 patients a day just on the COVID side of things alone. And what we realized from this is that just dealing with that one thing, do I have COVID or not? What do I need to do? Was actually just one very, very small part of things. So we'd used an AI tool to help with some of the decision support, but what we needed to do was use AI to help route people through a different service. So we're moving away from AI to more digital health technologies. And we looked at building something called a COVID care assistant. The idea being is that some people could care for themselves, but if they needed to get any more information, they could do so through simple messaging. And if necessary, they could then go on and speak to a video consultation or an audio consultation, or even see someone face to face. So smart routing patients through our service was something that we'd embarked on beforehand, but really saw its proof of concept through what we saw with COVID. And this is something that's happened across the NHS as well. So I think we've seen AI being deployed in this way too. We've also seen the number of people that need to be managed remotely. So we've seen remote care increase. And one of the most limited resources we have are doctors and nurses and healthcare professionals. So if we're generating lots and lots of data, we're beginning to see AI used increasingly to try and take some information out of all that noise to help guide what happens next. And so in terms of just wrapping up, because I know I've only got a short period of time here, there are two things that I want to sort of recommend here. The first of which is about data. Now, Dr. Joshi has already started talking about making large data repositories appropriately and securely available to help deal with the needs of our patients. And I think that's very, very important. It's also something that's called out in the TOPOL review, and I'll come back to that in a moment. But I'd make a plea that we also saw some of the kind of government guidelines being made available in a sort of similarly standardized format, or even in a machine readable format that would assist our clinicians and the people designing the software to implement it quickly. And then finally, I did mention the TOPOL review. Hopefully this will ring some bells with some of the people on the call, but the TOPOL review of 2019 looked at how we prepare the healthcare workforce to deliver the digital future of the NHS. Now, we've had a crash course in delivering the digital future of the NHS in the past year. And what the TOPOL review made recommendations, not only about data, but making sure that we implement training. And so that's the next recommendation. If we can start to pick up the training in digital health and data science, even in secondary schools and through medical schools, nursing and so on, to make sure that the practitioners of tomorrow not only know how to use the tools, but can help work with patients to build them as well. So those are the two things that I'd like to sort of bring up just now, and I'd hand back to the rest of you or face your question.
Great, Keith, thank you. Two questions arising from that. You think this isn't a one-off. This is basically a real step change towards digital health. Mm-hmm. Secondly, I mean, in terms of what you've said, we all know that Matt Hancock's a Babylon enthusiast, because it was about the first thing he said when he took over as Secretary of State. But how much kind of cross-sector collaboration with the NHS is there? I mean, you've talked about what Indra said about data sets and so on. But I mean, is there any kind of collaboration, cooperation during times such as the pandemic?
Yeah, no, absolutely. There's collaboration before, during, and hopefully afterwards as well. With GP at hand, we have an NHS general practice that's operating as a digital first approach, but that's also working with all the local commissioning groups and local services to work on innovative new ways forward. But be that oxygen saturation monitoring for patients at home, we're exploring new ways of doing cervical screening. These are the sort of things that NHS practice can do as well. But we've also worked in partnership not only with Universities Hospital Birmingham, Royal Wolverhampton Trust and Royal Berkshire Foundation Trust in implementing our symptom checker to help at the front end of A&E, because A&E departments, or rather before people got to A&E, because A&E departments were understandably under quite a good bit of pressure. And we've also entered into a long partnership with a 10-year partnership with the Royal Wolverhampton Trust. So yes, I think it's important that we do work in partnership here as well, not only with the providers of healthcare, but also academic organizations and some of the larger structures within the NHS to allow us to make a success of artificial intelligence. But artificial intelligence is just one part of the suite of things we do for digital health. So I think it's important that we play our part in partnership on that.
And that's happening in cooperation.
Yes, absolutely.
Interesting. Great. Thank you very much indeed, Keith. Now on to Dr. Eldad Kepten, who is the head of data science at the Clalit Research Institute.
I think I was planning to talk about another aspect of AI that proved very beneficial for us, both at the beginning of the pandemic and during the end. Well, it's not the end yet, but during the vaccination campaign. I just want to say that Clalit is a very large, is the largest in Israel health organization. We have 4.5 million members, and we've been communicating during the whole pandemic with different groups in Britain. It's been very beneficial on both sides. The basis for everything, of course, is the data collection, and I won't surprise anybody here by saying that when you collect data from a lot of different sources, community, hospital data, receipts for external services, and so on, you can get a much better comprehensive view of the patient and then train models that are much more detailed. And we've had both, we've done both prediction models and more statistical research that some has been published, some has been applied, for example, predicting for each member in Clalit, what is his risk of developing a severe COVID-19 if infected, or the amount of hospitalized patients in every hospital that we have 1 week ahead. Now, all these models, it doesn't really help that I have them in my group on my computer. It somehow has to reach all the members in Clalit. We have to contact that 75-year-old grandmother and tell her, look, you should stay at home. There's a pandemic going around. And it seems that she should know that, but remember, we're serving all sectors of the population. So what we have in place as we're gathering, and this has been in place before during hard work along the years, as we're gathering information about our members, we have a mechanism to send the recommendations back to the members. Now, it's not directly from me. I don't know how to communicate directly with that 75-year-old grandmother. What we have is this kind of waterfall mechanism that the model and the recommendations of the model are gradually being fine-tuned and simplified all the way back. So I would be working with a domain expert, with a medical domain expert, and he or she would translate, they would translate the recommendations to the family doctor, to the community doctors. They would help me refine the message so a general practitioner could understand the explanation, the causal explanations, or the explainable, it's the field of explainable AI. What are the risk reasons for that patient, for that member? And then that general practitioner, they would they would contact their patients. And this proved very beneficial at the start of the pandemic, where we could caution all of our at-risk members. And both during the vaccination campaign, we're doing the same thing in contacting those, again, those that are at high risk and nudging them towards vaccination. Now, those general practitioners, I mean, it's so as we're collecting data and we have the pipeline to close the loop. And this is crucial, but they won't believe any model that I give if we have fostered collaborations along the years that where we continuously collaborate in different domains with different experts about basic research and applied science, and allowing them to ask their research questions and use our AI models to answer their interests. And then when the pandemic hit, we already had these communication paths and the pipeline to send the message all the way to the point of care. And I think that my message is that my main message is that, again, AI models aren't just this magical thing that you can put in place and it will solve everything. You have to have the infrastructure to collect and to push back your recommended actions. It has to be in the right time and the right place in a very actionable, simple language for people to be able to act upon them.
Thank you very much indeed, Eldad. And just let me ask you, I mean, you've got a very interesting integrated model, which I suspect that we would aspire to here, you know, end to end. But how big is your ecosystem there? I mean, do you cover a whole city? You don't cover the whole country, presumably, with your ability to analyze the data in terms of risk and then communicate that risk via your sort of clinicians to the patients and so on. How big is the data set that you actually operate with?
Well, actually, we do have half of the residents in Israel are part of our data set and have been data from them has been collected for several decades. And then when we send our message forward, because in Israel, every resident has an allocated GP, then we have the mechanism to send the information to that specific GP and tell him for that specific person what they should tell. So actually, when we send out recommendations, we're sending them out to half of the population.
I think you're making us all feel very jealous in that case, because that sounds as though, in a sense, what we should be aspiring to. But maybe we'll hear from some of our panelists later on about whether, how far we are off that, or whether indeed that is our objective. But thank you very much. And now we're on to Dr. Natalie Banner, of Understanding, who is the Understanding Patient Data Lead for the Wellcome. Natalie.
Thanks very much indeed, Lord Clement-Jones. Real pleasure to be here. As Lord Clement-Jones said, my name is Natalie Banner. I lead Understanding Patient Data, which is an initiative hosted at Wellcome. And our aim is to make the way that health data is used a bit more visible for people, more understandable and more trustworthy. So what I mean by that is we try to create resources that explain how data from health records is being used, for what purposes, what safeguards are in place, and so on. We undertake attitudes and engagement research to find out what people's questions and concerns are. And by people, I mean patients, the public, and health professionals as well, because we know that quite often health professionals may be the ones that are in fact most skeptical or cautious about the use of data and the development of data-driven technologies. And then we try to channel those insights into policy and practice. So if you're setting up a data initiative, setting new governance rules, regulations, we want to make sure that those public views and values really feed in to those decision-making structures. And it's really crucial that public expectations inform the governance of data use in AI. And that's something that Parliament has an absolutely critical say in. And speaking of parliamentary scrutiny in relation to the pandemic, you see the report published today from the Public Administration and Constitutional Affairs Committee, I think I've got that name right, all about the use of data in the pandemic and government use of data. And they argue there that actually a lack of transparency over data use may well be undermining public confidence and public trust. Of course, it's really difficult in the context of a crisis, an unprecedented crisis hitting the country, to get absolutely everything right off the bat. But I think there's some really important lessons to learn from that committee report and from those insights about transparency and the impact that it, or lack of transparency, has on questions around public trust and confidence. So I'd like to pick up on Dr. Joshi's point about public trust and focus my remarks really on public attitudes and what we know about how people think and feel about the use of data and the development of data-driven technologies in light of the pandemic. We've certainly seen that people are more aware than ever of the fact that data is used, in the health and care system to drive new innovations and new technologies and new uses of data. National Data Guardian did some polling last year in the midst of the pandemic that suggested about 56% of people felt they'd learned something new about how health and data is being used to monitor public health and for research during the COVID pandemic. So it's certainly something that's much more prominent in the public mind and in public discourse. We're all talking about the R number. Who would have thought of that 12 months ago? But something that's very, very clear from the attitudes and engagement research that's been done in the past year to 18 months is that people will only embrace the technology if the rules and the governance are right. People are very keen to embrace data-driven innovation if it benefits patients and it benefits the health and care system, but only if certain conditions are met. Firstly, there's a huge appetite for information. People want to know, they're interested in how data is driving new technologies. And this is really difficult to achieve in practice because data is complex, it's technical, but also when it comes to health and care, it often involves the private sector. And that means it's going to be controversial for people because it is inherently going to be linked around questions of privatization and those sorts of things. So it is sensitive. There's no getting away from that. But actually being more open and honest may well be the way forward in terms of trying to assure people how data is actually being managed and used, what technology is being developed, how benefits are actually going to be created from the development of new technologies. The Centre for Data Ethics and Innovation recently did some research about how people feel about technology in light of the pandemic. And again, generally quite enthusiastic for the potential of technology to help manage COVID and sort of go beyond that and think about the recovery as well. But actually, the interesting insight was the trust in the governance of the data and how that was used was more important than the views about whether or not the technology works. So there's a real concern and interest in understanding the rules and who's putting into those rules, how they get decided for how data is used and what sort of innovation gets developed. And the same thing was found from the Ada Lovelace Institute doing a piece of work last year on the development of the contact tracing app. People want independent oversight and clarity on the boundaries, how the data is used, what it's used for, and so on. And they want there to be some level of citizen input and insight into how that governance is set up. So it feels as though in light of the pandemic, data is more available, tech is developing very quickly. The pandemic's really created a groundswell of interest. So it's very, very important to get this right. But we've also seen major issues in questions around data quality, accuracy, completeness. And we have to be open about the fact that technology and data-driven technology may run the risk of actually making things worse for some people. There is a risk that it could exacerbate health inequalities, not address them. We're never going to be able to level up the country if tech innovations benefit only the few. And actually, this was something we saw from a piece of work we conducted last year called the Foundations of Fairness, which looked at third-party access to NHS health data. 81% of people we surveyed believe that the benefits from those kind of health data partnerships need to be spread across the NHS fairly. So you don't just concentrate innovation and development in certain areas and leave others behind. So it feels like now is really the time to act. You know, for parliamentarians, there is an awful lot going on in terms of policy and longer term thinking beyond the pandemic. So it's really critical now to start thinking very, very carefully about what different governance mechanisms we need in place. And that needn't be an enemy of innovation. If we get the rules clear and everyone knows what they need to do and how to abide by them, industry, academic partners, charity partners, everyone will know what they can and can't do. And that will actually really help foster innovation and ensure that we really get benefits back to patients and the public and to the health system, and actually use technology in a positive way and not inadvertently make things worse for some groups. So I think there's a real opportunity here, but I guess my key message is the time is now.
I think that's an extremely timely point you're making there, Natalie. And it's very interesting because I mean, the PAC is quite critical, isn't it? I mean, but even down to talking about statistics and not really following the UK Statistics Authority's guidance and things of that sort. But I mean, do you think there is, because, you know, we have always thought in the all-party group that, in a sense, public trust is absolutely crucial if you're going to develop AI solutions because of the data issues. I mean, do you think there's an awareness of that in government? I mean, for instance, you know, the Secretary of State, in terms of announcing the new AI strategy for whenever it's going to be published in the autumn, I mean, trustworthy AI is one of the planks, isn't it? I mean, do you think that's just words, or do you think there's a real commitment to actually get over some of these issues?
It's hard to say when you sort of see the words, because as you say, you can very easily sort of nod earnestly and say, oh, yes, trust really matters. Yes, we need to be trustworthy. How does that translate into practice? And I think there's a few critical benchmarks you can use to assess whether you are actually taking the notion of trustworthiness seriously. And one of those is whether you are willing to change or adjust course depending on what you hear back from people. If you are going to put information out about this is the way that data is used, this is how decisions are made, that is a communications exercise, which is very, very important. I'm not undermining that. It's really important that people, you know, that data literacy improves and increases generally. But the critical thing is, are you actually willing to listen if people are expressing concerns or questions? And they say, well, actually, we have some red lines here. We're really uncomfortable with the idea of data being used in this way or this kind of technology being developed. If you're not being responsive to those concerns and those questions, then I don't think you're doing much to actually develop the trustworthiness of the system. So for me, that will be the real critical marker to see if there is actually any effort to try and respond by the system to the questions and concerns that people might be raising.
Thank you very much indeed. Now, Raja Sharif, who is the founder and CEO of FarmaTrust. Raja.
Good evening, Lord Clement-Jones, and thank you very much for having me on board here. And just by way of background, FarmaTrust is a blockchain track and trace solution, which we started back in 2017. Over the years, what we've been looking at is what do we do in terms of all that data we collect. We specialize in the pharmaceutical and healthcare sector, so we're familiar with these issues around data sovereignty, NHS hospitals' requirements to keep data on-prem, as well as dealing with GDPR and data, sensitive data issues. So what we normally do, and as I'll speak, I'll just share my screen, is we track pharmaceutical products from the point of production to the point of consumption. And we also give full chain of what they call custody, identity, and condition. That means you will know who had it, when they had it, and how long they had it for. So I'm going to give you an anonymized version of one of our dashboards, just so you can visualize this rather than talk about it in an abstract way. So this particular entity, if I can just move it, as you can see, has a number of premises throughout the UK, and they can look into each particular area or sector and discover how many deliveries or packages they have there. They can even measure KPIs and SLAs. But, you know, just so you can see how granular we can go into this kind of data, we can actually look at individual product codes, batch numbers, quantities. We can even see the user the time it was used, and the expiry date. So the reason I'm showing you this is just to show you practically, rather than talk about it in an abstract way, of how deep we can go with data. Now, last year, what we did is we started moving slowly away from just the product data and seeing what happens when you administer that product to an individual. So since we can track things like medicines, medical devices, vaccines, and test kits, we thought it'd be a good idea if you could also track the person who had that vaccine or took that COVID test. Of course, we can also track tissue samples, which we use in stem cell and other theories. Now, the great thing is with blockchain technologies, one of the things, coming back to Dr. Banner's point, is you have real control over your data. And you can see who's accessing it, or actually give them permission to have a look at your data and when they have that data. But because of the granularity of the data that we collect, not only can you use AI to help with things like eliminating fraud or waste or over ordering, but you can also stop stockouts or shortages, or even distribution of medicines, because you know who's going to come in or what the demand for a particular asset is. Now, predictive analytics like that is actually the kind of day-to-day machine learning or AI use, which gets away from the problems that that really takes up a lot of people's administration. Now, we also talk about why or how can we facilitate research in medicines or published health. The great thing, of course, with these new technologies is data can be anonymized very easily. The systems tend to be built on cryptography by themselves, so they're incredibly secure, much more secure than most cloud systems that you might have. And certainly companies like ours recognize the need to be technologically neutral, i.e. we can take data from lots of different data sources and aggregate it upon one platform, and to even be, say, blockchain neutral, i.e. you're not tied to a particular provider in the future. And that, of course, also requires a certain amount of planning and data dictionaries, as we've done with certainly one hospital here in the UK. You mentioned an issue about citizens' attitudes towards data. We tend to get the sense that citizens generally don't mind their data being shared if it helps them or helps society in a broader way, but they do have concerns over whether or not data is being used by commercial entities without any return on investment, either to them personally or to the NHS or the government generally. Now, in that regard, what we're doing is we've started discussing a project with one of the colleges in Oxford University, where as part of clinical trials or data sharing, if a subject withdraws access or their consent for access to their data, then access is denied, not just for the company that directly took that data, but layer 2 or 3, i.e. those companies that are using it indirectly as well. And these kind of technologies are available. What the issue is here is a lack of understanding of them or willingness to use them. As we know, some people are concerned that they don't understand a particular issue and therefore don't want to take a risk with it. But you know, these kind of technologies that we have now really can help the economy, help society in general. One of my colleagues got a vaccination a couple of weeks ago, and I asked him, what did they give you as proof that you've been vaccinated? I mean, vaccination passports and health passes are all the rage in terms of discussion. And he showed me one of these, which was a cardboard bit of paper. Now, what I said, well, can't you just give that to somebody else and say, look, I've been vaccinated, because there's no identity information. What they could have used was one of these. Now, because we use blockchain technologies, that means the data on here is immutable and incorruptible, but more importantly, I can control who has access to it. So a MetroD may only need access to see this with their verification app for a couple of minutes, whereas an airport or a government or an immigration may need it for much longer periods. And one of the things that AI and machine learning generally needs to be underpinned is with good data. And certainly one of the recommendations I would make is it's not just to look at, oh, what's this app? Because for us, apps are pretty cosmetic. It's the infrastructure underlying these technologies. Is it interoperable? Can you give access and take away access to particular bits of data? Do you have the ability to move to better, faster systems in the future? So those, we do talk a lot about the kind of what we call the front end layer technologies. But I think one of the things certainly that we may need to do in this country is to look at the infrastructural issues underpinning supply chains and other healthcare related technologies.
Great. Roger, thanks very much indeed. I mean, I think you've illustrated how very much data ethics, and as I think Natalie did really, are bound up with the whole issue of the use of AI. And but by the same token, of course, there is certain health data, personal patient data, that suitably anonymized. In a sense, I would say that as a sort of generality, we don't want to have explicit consent in every case, and this is one of the conflicts that we have, isn't it? I mean, how do you get over that? Because, you know, in a sense, if doctors, you know, had to before, in a sense, amassing data about conditions and so on, as we've heard earlier, to get individual explicit consent every time. You know, and then to be subject to the kind of mechanisms that you were talking about, real control over data, I think was the phrase that you use, you would soon find yourself without a representative set of data, wouldn't you, in healthcare? I mean, how do you make the distinction in your own mind? I mean, the NHS relies upon very large data sets in order to then use those for the benefit of public health. One could say. Do you make a distinction between the private sector and the public sector in any shape or form?
Well, I mean, just on that point, and it is a complicated issue, the thing is, these are merely tools that you can build rules into. The politicians and regulation and laws govern these tools. So if you say, well, the NHS must have access to all data because they've got a particular private key that allows them to do it, then that is a rule we build into technology. Now, remember, we're not like the only country tackling these systems. There's Estonia, which is one of the kind of pioneers in health records and how data is accessible. You can go from one private doctor to another private doctor, and you give them consent and take away consent when you leave. So there are, of course, issues that we need to decide, and there needs to be public debate. But in terms of the security, privacy, and control technologies, we have them right now. We could use these kind of technologies right now to open Selfridges across the road, because it will tell you who's been tested and they are negative, or who's been vaccinated and they should be allowed in.
But it could be a partial solution to the sort of things that Natalie was talking about.
Absolutely, absolutely. These are
making sure that we have public trust. Yeah. Okay.
Exactly.
Thank you very much. And then our final panelist, Jonathan Levi. Nice to see you, Jonathan, who is the CEO of, I don't know whether you pronounce it HACERA. Is it a hard
HACERA,
C?
yeah, that's correct. Yeah.
It's a soft C, HACERA, and founder of MiPasa. You obviously like exotic names for the companies that you found, Jonathan.
Yes, my father was Spanish, so yes. there's some influence there. Yeah, so what brought me, so just for, this is the background, my name is Jonathan Levy, I'm an applied cryptographer, mathematician, and I actually spent a lot of time in the military with cryptography, and then around 10 years in banking. So in the previous world crisis, I was actually on the London desk in Barclays Capital, and all I've done with my math was to take over Lehman Brothers and then later on Goldman Sachs. This time, I thought that we should do something useful with our skills and actually try to use cryptography and all of our mathematical and analytic skills to help the world. So we built MiPasa. Just very quickly, we are also a blockchain company, so we spend a lot of time working with multiple parties that connect to a network where they share data. So COVID really basically came right into the same space, because before that we worked with IBM and Oracle and Microsoft. So we worked with many clouds and worked on a lot of infrastructure products where we needed to share information, but not with everybody. So Rajan mentioned that they can add some form of a private key that is special to an auditor. In our solutions, there's always an auditor. So everything has a separation between the private kind of sharing of individuals or companies or group versus the public version. What we have done, we actually took the same technology that people use for supply chain or to decompose a hamburger to see where is the bun from and where is the meat from, and basically go to the entire procurement process. And we did the same thing with data. MiPasa is a browser-based cloud-native platform that allowed us to integrate data from Johns Hopkins University, from Oxford University, from New York Times, from every country that actually shared initially COVID data that was a public data set. And what we wanted to do is basically to bring everybody to the table. I realized very soon, like very early on, by mentoring a few hackathons, and our team we partnered with a lot of big players that actually brought us into the solutions. And the main problem that we saw, people talking about responsible AI. I was coming in from, let's try to build what we call reproducible AI. So basically, there were a lot of hackathons where people built models against some data. And let's say they won the hackathon of the weekend and nobody slept for like 2 days. But then on Monday, if CDC Europe basically removed the column, if everybody here remembers, that we used to think that there's like the confirmed cases, and then we have the dead cases, and then we had the recovered cases. And then a few months after kind of the publications, they realized that actually some cases did not really recover. They just removed the column. And all the models broke because all the machine learning and the AI models were relying on the structure of the data. So what we have done, we actually built a system that can work with multiple languages. So we can get data from Estonia and from France and from London and in different time zones. And we looked at different metrics, right? So some things were with different, it was UTF-8 and different locale settings. And the timestamps were different because Serbia was publishing stuff at 3 p.m. And we basically put everything, I'm happy to share a screen and just to show it. We basically allow people to look at unstructured data, just very quickly, unstructured data that you are always in sync because the data basically is always UTC. All the data and the country codes, I can easily show the platform. So when you come to MiPasa, you can just go to a data set and you can see everything that is published. Now I'm gonna show only the public part, but basically instead of looking at data like this, and this is the data that is published by CDC, we can actually go in and look at the formatted version where we can actually code against the data. So if we look at, let me just show featured, I can easily program against the data, look at multiple parties that look at the same data set. And these are like hackathons results and people that build models against the data. And not only that we have a way to look at the open data and the columns and the structures, we actually allow people to publish their research. And not just that, we actually allow them to also publish the code. So if somebody is worried about how this diagram in particular was published, we can actually build kind of a supply chain with all the versioning. And I'll show another model that actually won the first place in the Wharton Hackathon, Okay, it's a k-means clustering model that basically looks at dimensionality reduction with machine learning and AI. And basically, if we look at this model and the data that they published, we can actually look at all, I'll just zoom out a bit, at all the data that was published and the models that are using what version of the data to produce each and every model. So we support machine learning, AI, statistical analysis, but our main thing was to version all the COVID data as it arrives, to version the code and the models and the AI modeling that was used to generate the insight, and to basically create a very reproducible end-to-end results, so that if people make mistakes, and we see it all the time, right? There's a lot of data and people are working under a lot of pressure, right? From Switzerland, Sweden, Israel. In Israel, it's a little bit easier, to be honest, just to support what Eldad was saying, because the systems are a lot more digital and Clalit has a very wide outreach. But in the UK, or especially in the US, when every caregiver or care provider needs to work with many partners, right? And some of them can be like infrastructure partners, like Microsoft, or I don't know, now it's like Palantir. But at the same time, they also have caregivers that they need to share information. So our system allows you to basically define what you are sharing and under what condition, to work with unstructured data, and to code against this data with very minimal effort. So the idea is that everything is cloud-based. You can work on premises. So basically, people shouldn't worry about exporting data if they don't need to. There is full visibility as to who can access, who can read, who can update, who can model against data, and actually to look later on whether people are using the data that we publish. So we saw a lot of independent organizations like CDC and WHO and the NHS through Oxford University, and we see a lot of things around Europe. And they publish stuff, a lot of the stuff we just published, not always in a machine readable format, and not always with logging. So it's very difficult to know whether this data is useful, right? What the difference with what we did, we basically aggregate a lot of data, create a time capsule of everything that happened around the globe, show a live map of all the changes, and then if there's any mistake, we actually are in a position to report a mistake and to say, look, by the way, this column matches exactly what happened yesterday, right? So the main concern is basically people who are afraid to make mistakes in publishing data, and it's normal and natural under such a crisis of such scale that not all the systems were up to date. There are people that are modeling stuff and they get bashed many times. So we wanted to allow them to actually publish their models and to get feedback about the models and to start conversations. And later on to look at the results in a way that we can easily compare them. So we wanted to have visibility, transparency, and a reproducibility across the entire kind of food chain, right? But it's the data chain. And that's what MiPasa did. And that's, you know, in 1 year, like we got so much love from everybody, including the UK Parliament that invited us last year. And we got a lot of traction with a lot of more than just data providers relating to COVID. We ended up with vaccination data and later on financial data and bankruptcy data. So we actually ended up building a fully functional software as a service platform based on the need that we realized and we learned through that crisis, just by coming in and helping everybody. And yeah, that's one of our key products now. So people can come in and code, people can come in and share, and they can discuss it. It's a fully collaborative platform that allows people to just easily deploy a model and just share it with others, share it with teams, allow them to control what they do and for how long. And there's full governance around the data, the models, and the insights or the outputs across the world. Yeah, so if we can help anyone here or other people, we would love to. But AI is a key aspect, especially because it relies on so much data. And when it comes to healthcare, it's very sensitive data. And I don't know, some people allow Facebook to do a lot more than they allow them to do with, you know, the symptoms. And I think we should be a lot more worried about what you share with partners. It's a big organization, and for how long and under what conditions. And it's true that it's difficult to make a request every time under crisis, but we have a set of policies that can enforce the whole data kind of, I call it supply chain, but it's really the whole data economy, from fetching the data all the way to using it as well as publishing it and using the published data. So it's a full end-to-end solution that really guarantees that we meet the strictest rules in terms of data privacy, compliance, and sharing, as well as exporting. Yeah, so yeah, that's MiPasa.
Thank you very much indeed, Jonathan. I think what would be really helpful, because that sounds a really interesting and useful set of tools, so to speak. And if that's the product of your hackathons, I think we're lost in admiration, basically. But just give us a flavor of the practical application, because you put a whole bunch of brands up there and so on. Just give us an idea during COVID what the practical application of your tools would have been.
If you don't mind, let me just give some credit to the people that won the hackathons, and I can show you some models that I think were mind-blowing. So this is a model that basically trying to understand what are the most resilient states during COVID-19, and basically just looking, instead of looking at all the data, is actually how can we reduce dimensionality, and basically to look at the impact. And we saw that actually some states are just very similar. This is what we call in math dimensionality reduction. Instead of looking at 50 states, I can actually look at the spectrum, say, most of these states act the same. So this is one thing. Another article that made a big impact was actually when we looked at different states in the US, and these were the winners of the Wharton Hackathon. So yeah, we are super proud of them. They basically try to combine data from different sources and to actually look at, many people were complaining about, are we too aggressive with the way we do the lockdowns, or are we too, willing to, it was too easy and we should be more careful. And basically the whole methodology here, for example, thanks to MiPasa, they were able to publish it and share it. They were actually trying to calculate what is the actual cost of 1 day of lockdown. In New York City, London, Tel Aviv, these are different prices in cost of living. If you are relying more on tourism versus you are relying more on labor and export. And they also looked at what happens next, right? So if I look at, I had the lockdown, how did that affect the case? If I closed bars and restaurants for a while, what did it do to the economy? How many more unemployments were registered in each state? And how many more cases were reported? To be honest, it's easier to do it now in Israel because it's a lot more digital with the vaccination, by Pfizer, and everybody was helping because it was a very good case of a very strong lockdown with airport closed, so we could do it. But these are early days where we really didn't know, and the moral was very low. And we had so many issues about trust with the data and the government, and what do they do with my data, and are they going to sell my data, and do I trust Facebook with my location data? There are so many issues there. And what we liked in particular about these kind of models is that students just looked at publicly available data, added and combined different data sets from different places, and actually tried to look at, what happens to COVID in the economy, what happens. So is it true that countries that are more like an island, like New Zealand and the UK, are more resilient because they're an island that is easy to close them, and some very different questions. And they were very easily answered.
Thank you. I think we've heard quite a flavor, and we need to get on to the questions now. And I admire your enthusiasm. Thank you.
Sure. No problem.
The question is whether policymakers are picking up on, some of the output. I suspect at the end of the day, which your analysis is giving us. So that's an interesting question in itself. I'm going to just put about 3 questions. The first question is so that then we can get a cross-section of our panelists answering some of the questions. My first question, it comes from Tirath, and he asks, what are the panelists doing to enable what he calls the democratization of data to their consumers? I think the sort of thing maybe that Roger was talking about to some degree, but I think we might put that to some of our other protagonists who are involved in this. And then I'm going to ask Samer Sawas to ask his question. Samer, would you like to ask your question?
My question was concerning the the global reach that Babylon Health mentioned earlier on. There's clearly a restriction in terms of data accessibility and reach within every country. How is it that Babylon Health is managing to go around this obstacle?
Great, thank you. And then Tom Pickering will be our third. Tom.
Hi, thank you for the invitation to ask a question. So very briefly, I'm particularly interested in the psychology of how strategic projects like this can become dislodged and go off track, mainly around the psychology of blind spots and critical thinking. So the question I've got specifically is, if you consider what doctors and nurses talked about 10 to 15 years ago, which is around doing paperwork and taking them off the front line, how actually is this affecting productivity, given the fact that there's a huge focus on data collection, and what's that doing to the availability of frontline staff and the redeployment of frontline staff, but also the activity that's involved in managing the data, making sure the data is clean and usable, etc. So my question's really around, the productivity and utilization of frontline staff, really.
Great. Thank you very much, Tom. And I'm actually going to have a fourth, because I want to make sure that our panel all have a question that they can attack, because they won't necessarily want to answer all of the questions. So I'm going to ask Edward Cole if you'd like to answer ask your question, Ed.
Clearly, my question is about infrastructure, which Raja spoke about. My company has used very similar technology, blockchain enabling technology, which is based on individual patients having their own wallet, being able to collect medical device data and questionnaire data, which they can then share with an AI system or any clinical research organization, and get information back that predicts the likelihood of cardiovascular problems created by COVID-19. So why is this interesting? Because this can be applied in many, many areas, and it solves this problem about the AI life cycle, if you like, for AI-driven technology, which is so worrying people who observe the more private institutions. And Babylon Health is often cited, as are many other companies, that are using AI from alternative sources than potentially the data that's coming from our public systems, with the provenance guaranteed and patient consent maintained. My problem is I see all the potential that Raj has talked about. I see even lots of bigger data analysis with consent or provenance that HACERA has spoken about, but actually it's very difficult to get anybody within the health system to actually look at this. And when we look at this in terms of the future, we're all going to want to go to public events in a minute. We're all going to want to get out and about, and we won't want to tell everybody our every movement. We will want to share what we call a health passport, a vaccine document, if you will, that you can match against your face or can share with a camera in an inintrusive way, and perhaps have your temperature taken without necessarily people knowing who you are, just to know that you're safe to go into that public place. I'm not seeing initiatives, and I'm not seeing reception from the health organizations, maybe with small business, and this obviously it's great for me to speak to you guys, and I'll be as brief as I can, but I'm not seeing any avenues or ways of getting in front of and solving this problem when these solutions do exist.
Okay, so that's great. Thank you very much, Ed. I think we've got the gist of that. So I'm just going to go in the order in which the panel spoke, and just answer the questions that you think are either interesting or within your sphere, so to speak. Indra.
Great, thank you. I might just pick up on Tom's point around the productivity and utilization. So one of the key things as part of the NHS AI Lab, we've got something called an AI in Health and Care Award, and we range the technologies from what we call phase 1, early stage technologies, to phase 4. And we're working really closely with both NICE, the MHRA, CQC, but also with HEE to really evaluate in the real world exactly those questions. And one of the things is we do hear a lot of claims about the technology and what it can do, but actually a robust evaluation will really help us formalize some of that. And so we are working towards that. But in reciprocal, when you look at a lot of operational technology, so we have seen a couple of technologies, especially in the imaging world, where they are basically automating some rather, I mean, I've had to do this in the past as well, you know, circling around a tumor or a malignancy in a radiograph, they can do that. And so that is freeing up time. The question is, how do you actually collate some of that information? So the work is there, it is happening. I think over time we will see some really robust outputs from those evaluations.
What about the two other points, Indra? I mean, Ed's point about vaccine passports, where NHSX must be fairly intimately involved, and B, the democratization of data. I mean, the assumptions that you as NHS make about NHS data being available are not assumptions that somebody in the private sector can make, are they? But that means that therefore you have a special responsibility in a sense.
Say, I quite often talk about this when we talk about data. People say, you know, where is the data? How do I have the data? And we quite often flip the point around to say, well, what's the problem you're trying to solve? And if it's very clear what the problem is you're trying to solve, then having access or asking for access to that data becomes much more straightforward. And examples are, you know, the HRA, the Health Research Authority, have very good, robust ethical frameworks on how to access that data. But also HDR UK, Health Data Research UK, have set up something called an innovation gateway, which is where access to data and how to access data sets are there. It's on the platform, as do NHS England. They also have access to data or what data sets they hold on their platform. So I think the question around data and how to access data, people have the perception that the NHS is this kind of one-stop shop, but the reality is it's many different institutions under an umbrella, and actually being really clear on why you need that data and what the problem is you're trying to solve inevitably helps a bit more.
Yeah, which implies that you have to, you know, make sure that you are very open about the data you're using and publish on, you know, all the necessary websites, so to speak. Thank you for that. What about the vaccine passport point, though?
I know a lot of work is happening with partners like NHS Digital in this space, but I don't have further information on that right now.
Yeah. And there's just one other point. I mean, clearly, when you have partnerships with the private sector, then, I mean, you know, sometimes in the past issues have arisen, for instance, DeepMind with the Royal Free, things like that. I'm assuming that it's kind of once bitten, twice shy, that there is now a pretty tight system of governance in that respect.
In health, we're very fortunate compared to other industries, I would say, where actually we work very closely. We have quite good, robust systems from the regulators I've mentioned on access to health. We follow other health regulations as well, into other data regulations as well, such as GDPR. So I think we are quite fortunate in health on that access to data question. And yeah, I'll pause there, conscious of time. I could carry on talking, but I will pause.
Thank you. Keith.
There's a lot of great questions, but maybe what I'll do is I'll pick out two that I think are probably kind of aligned, or answering one helps me answer the other. There was a question about democratization of data, and I'm sure those, you know, we've heard some really good presentations about how blockchain can be used to allow people to have very, very fine-grained control over their data when it's used. And the example of Estonia's quite rightly brought up, you know, very advanced ways of managing this as well. I think ultimately democratization of data comes down to people knowing what data is collected on them, and then what it is used for. And certainly I can speak for within Babylon, that when people use our services, when they sign up to this, they're given some information that's presented in hopefully a digestible form and summarized form to them to understand what the data will be used for, and they can choose to opt into that or not. So they can choose to opt in to have their data collected to provide the service that they've immediately come up for, but then they also have the opportunity to opt into whether that's used for the improvement of the data model, the AI. So a person could say, I just want to use my data for the purposes of my care and getting an answer right now, but I don't want you to use this for the purposes of training the artificial intelligence or developing this product any further. Similarly, questions about the use of data for the purposes of research and publication as well. So there are some levels of control over this as well. And the question is how you balance it, whether you give a person extremely fine-grained control or whether you try and give high-level control as well. And you vary it from situation to situation. So that's one way that we approach this just now. And then going into Samer Sawas's question as well about Babylon and our global reach as well. So, and there was also a question, I think, in the chat about how we provide primary care services in one country if we're based in another. I mean, the important thing there is that we're always going to be compliant with the data governance rules of whichever country that we're operating in as well. And so if that country or region requires that patient identifiable information or sensitive data remains within that region, that's exactly what happens. It remains within that region, and we configure our services to do that. So data is not being moved around from that perspective. What we can do, and what is commonly done as well, and this is made clear, is that if any of the patients consent to this information being used for the improvement of the model or anything, then that data can be not only anonymized but then processed in such a way that it is impossible to re-identify that, and then that can be moved around as well. So this allows us to comply with data governance, but also allows you to use some of the learnings from some regions. I will say on top of all of that, that I am not the data specialist within the company. And so for a formal answer on that, I would direct anyone to send any questions to me. Very happy to get a more formal answer to you as well. But hopefully that answers at least some of the questions that were asked.
Great, thank you very much, Keith. And Eldad, just tell me, I mean, from your perspective, I'd be very interested to hear about the vaccine passport, if that has been created. But do you have a GDPR equivalent effectively in Israel?
Well, actually, we confirm to the European GDPR in almost everything, both in our system and I think all over the ecosystem in Israel. Regarding the passport, well, we do have that in place. That was not organized by the health organization, but by the health ministry. And so they're in charge of collecting the vaccination statistics from all the HMOs and aggregating them together and giving the app or, well, usually it's through an app with you can go into restaurants or in gyms and so on. Of course, it's been an issue of public debate as anything about what is the best manner to do it. But in the bottom line, it's rolling out and people are using it and they seem to be happy with it. I would be happy to answer the question about democratization of data.
Yeah, why not?
I think I would suggest a different approach because data is private, and people shouldn't be expected to share their private data with even other health organizations or researchers. What we want is democratization of research, which means that the data should stay in the hands of where the patient requested that it stay, but people should be able to do, researchers should be able to do research with that data. And there are technological ways to do it. I think Jonathan gave an excellent example. And that eventually is the goal. And from a public health perspective, what you want is researchers to research, not to hold private data. So democratization of research through technology, I think is the best way forward.
Well, that's a really interesting lead-in to Natalie in that case, because I suspect you've because of what you said earlier, Natalie, you would have quite strong views in that area too.
Thank you. Yeah, interestingly, I think I probably take a slightly different view. I worry sometimes when we talk about issues to do with data that we end up thinking that all of the kind of ethical and governance issues fundamentally come down to privacy and consent, and we end up creating systems that then put quite a lot of burden on individuals to know what's happening, to be able to have the capacity to make decisions, to themselves take on quite a lot of the responsibility for establishing what happens to their data. In the same way that when you download an app and you sign up to the endless terms and conditions, technically speaking, you're supposed to, take all that information on, but I wouldn't necessarily say that's kind of meaningfully transparent. I would say that democratization of data is far more about the institutions and infrastructures and governance mechanisms around data that enable people to be safe, even if they themselves don't necessarily know or want to make a decision about exactly the sort of fine-grained circumstances under which data about them could or couldn't be used. We've got to have those institutions and infrastructures in place. I don't want to have to take a water testing kit with me every time I turn on the tap. I want to rely on the systems that exist to know that that water is safe. And I think the same should be true of the use of data and the development of AI. It shouldn't be down to the individual every time to take on that ethical responsibility of knowing exactly what's happening and making decisions individually for themselves. My worry, if we do go down that route of focusing it very much on individual levels of control, is that you disenfranchise huge amounts of the population. And this comes back to the point I was making earlier about health inequalities and the risk of actually really leaving some people behind or making things worse for some people, because there's an awful lot of people who are not going to be able to participate in these kinds of discussions of these technical issues. And that's not to say we should ignore them. We absolutely shouldn't. They should be at the center of the decision making. But it does mean that we need institutions and governance structures in place that enable them and enable their data to be safe, even if they're not the ones who are in the driving seat of all of those decisions.
So if, on the basis you said that, very firm, where do you sit on things like vaccination passports?
Well, actually, I think the Ada Lovelace Institute is doing a huge amount of work on this and exploring, fundamentally, these are value judgments, right? These are value questions, and they are going to need some political and value-based answers. So I think that actually what we need to be doing there is undertaking, a substantial amount of engagement and dialogue work to explore where the boundaries are for people. What are the red lines? If you go down a vaccine passport type route, who do you disenfranchise? Who gets left behind? Who isn't allowed to then go to work because for whatever reason, maybe they can't have a vaccine, maybe they're anxious about a vaccine. There's good reasons to be anxious. This stuff is very new. So I worry that if we go down the vaccine passport route without paying attention to the fact that there's an awful lot of people who might have good reasons for or be unable to participate in that kind of scheme, then you end up leaving a lot of people behind and actually making things worse for quite a few.
Thank you very much, Natalie. Roger, just a couple of questions you'd like to answer?
Yes, I mean, coming back to Edward's point, infrastructure is a difficult one because we are changing from the traditional kind of technologies into much more future-proof technologies, certainly the ones that we're working on. And it takes time for people to understand them. It makes it difficult, but the overall thing is, celebrating apps or the fact that we're using cloud, which has been around, for over decades, is not what we need to look at. We really need to look at these new technologies that can help society. In terms of vaccine passports, I've showed you one that that's being used by employers. And the reason is, I mean, not only are there some ethical considerations, the fact is, it's just ease of use. Your mobile phone can operate a turnstile to your office, or it can make it easier for you to go into a restaurant, for example, just by swiping, by using the NFC chip. And as I said previously, you are in control of your data. So the kind of, discussions or arguments about, well, what are the data issues? I don't think with our kind of technologies are there anymore, because you can pass that responsibility to the user themselves. In terms of informed consent, I think it's a little bit like the cookie policies that the EU have to kind of come in. I think making it easier for users to have a uniform consent process makes it so much easier. I don't want, for example, my health data to be used for animal testing. Okay, I may have allowed that in the past, but maybe what happens if I want to withdraw it? And you need to look at technologies like the ones that we provide to give that choice to users. And it comes back to that freedom or democratization of user. We have the tools. The issue is, why are people not using them? And that's where the discussions need to be. Telehealth has been around decades. It's not what we need to talk about.
Well, I think we've opened up a very interesting, not quite fault line here, but certainly a very interesting area of debate as to the extent to which health data is and should be available and subject to what conditions, which we're not going to resolve this evening. Jonathan, and then we'll come to another quick couple of questions, and then each of our panelists will give us their 2 sentences to round off with. Jonathan.
Yeah, sure. So I have kind of 2 heads, right? I have like I'm kind of a law-abiding crypto anarchist, right? So on one hand, I like decentralization and blockchain, and let's share, and let's not have the bank control everything. At the same time, I don't believe that we should just share everything just for the ease of use, right? So I'm much more in tune with what Natalie is talking about in terms of like, why are we anxious? So just to say, let's have a mobile app that has all my medical records and my blood samples and all my PCR tests. And sometimes I'm just gonna, forget my phone somewhere and somebody can unlock it. So it's not that simple to allow people just have all the data on a cloud or for the government or with a government partner like IBM or Microsoft or Palantir, again, that basically has access to all this data, especially when we all know that the insurance companies would love to get all this information. So the governments and the regulators are there as kind of the watch guards, and they have a purpose, and they are rightly so. So I don't believe that we should put everything in an immutable way where we cannot erase stuff. Everything is shared forever. People make mistakes. People reveal stuff, unknowingly. People are tricked into personalization while giving away a lot of the privacy rights that they rightly have. So I believe that actually, especially with AI, where compute power is so cheap and is so strong, I would be a lot more careful about how much I'm sharing and with whom, even sometimes at the expense of the kind of quality of life and ease of use. Just in one more sentence, please, before you interrupt me. What Eldad was saying is something that we used to call, don't share data, share insights. So you don't need to know my zip code, my blood sample, what was my grade in school, to know that I'm more likely to develop like severe symptoms. So sharing insights, sharing research, sharing a lot of information about anonymized data is highly welcome, because we need this information, but not all the data with everybody all the time. That's
Great.
A no-no.
Thank you very much, Jonathan. Now, I'm just going to squeeze in Ruth Hillary's question, and then I'm going to ask the panel, if they can answer it, to do so, but actually then to give me their sentence about what they predict for the coming year in the terms of use of AI. We want to end on a really bright note for the future, or not, as the case may be. It may be you see a terrible year ahead of us, but just in case you don't, tell us what you think that the most significant use of AI will be in the post-COVID era. Right, let's just ask Ruth to ask her question.
Thank you. Many panelists have mentioned the issue of trust and governance. So my question is, what, if any, standards, international, regional, national, should be being developed now for AI use in the medical sector?
Great stuff. Thank you, Ruth. I think what we do is we get one sentence from our panel on that, and then another sentence on how they see the coming year and the application of AI. And I'm going to do exactly the same as I did before, so I'm not unfairly catching people by surprise. And Indra, starting with you.
Brilliant. So just to share, Ruth, we work very closely with the WHO and ITU. So they have an international working group called AI for Health. And we are part of that as the UK, and they are developing both standards on regulation, clinical evaluation, as well as benchmarking models within the medical healthcare space. So work is undergoing, but underpinning that is quite a bit of work also on interoperability, which is led by something called the Global Digital Health Partnership as well as other technical bodies. So there's quite a bit of work happening. We did publish a report, happy to share the link with you, on how we could start formulating more wider policies on that. And just an end note, as the lasagna beeps in the oven, is to say, if we've got a number of programs we've set up in the NHS AI lab. If we deliver some of those over the next year, that would be a good thing. There is a lot of talk about AI in healthcare. I agree with a number of the panelists, but we do have to show, we have to demonstrate, and we have to prove some outcomes. And if we can do that over the next year, we will have shown a little bit of success.
Fantastic. And you definitely deserved your lasagna there, Indra. Thank you. And then on to Keith Grimes.
Yeah, sure. Well, actually, before Indra goes, she has to hear, of course, that I will praise the work of NHSX with the Code of Conduct for Data-Driven Technologies, as well as being an excellent way into this as well. We've seen nice published guidelines on how they're going to evaluate technologies as well to show this as well. There's lots and lots of different guidelines out there as well. I think all I will say from our point of view is, we do what we can to comply with all of them, those that are legally required, and all the sort of recommendations as well, looking for some of the dust to kind of slightly settle, because there's quite a lot of them at the moment. And a large part of the work that I do within Babylon is to try and take the best of these and at least boil it down to something that we can practically use in what we do day to day to put, to build the technologies and test and validate it and so on. So within Babylon, we use a clinical digital health governance framework that's been developed off the back of clinical governance, informed by some of these recommendations and codes elsewhere, to try and at least guide our hand as we operate internally, alongside complying with other standards too. But I would say that there's a lot of different standards and codes out there, and some of them are very similar and some aren't.
Okay, and one development.
Oh, yeah, funnily enough, right, okay, so the one development next year, risk stratification. Okay, right, we've collected loads and loads of data. We've got a massive backlog of people that need care because we've been focusing on COVID. We need to work out who needs to get care first. AI crunching that data, that's the thing that's next.
Great stuff, that's what we wanted to hear. Eldad.
Yeah, so first, if I can just mention in a sentence, answer Maria Pavlova that asked how we integrate ethics into our work. I think we look into that crucially in every project that we give out to the community, because ethics is part of trust, and our members have to trust us that we're using their data also ethically, and that they get answers that are surrounded, that are ethical eventually.
And one development next year.
So I think we're in an excellent position both to create standards about AI in the field. I think we've gained a lot of experience, and I think we should all be collaborating on that.
Fantastic. Brilliant. Thanks very much. Natalie?
Thank you. I'm not going to back a particular AI horse, perhaps unsurprisingly, but I think the development over the next 12 months is going to be around this question of infrastructure, of who is responsible for what, the collaboration between public sector and private sector, the decisions that need to be made, in terms of democratic accountability. Those, I think, will, if we can make those well in the next 12 months, they will set us up on a very strong path. If we don't make them well, then I think this technology and all of the potential could very easily be wasted.
Thank you. As parliamentarians, we note carefully. Thank you. And then Roger.
Well, in terms of regulations, there's so much regulation already out there, including international standards that we all have to abide by. Obviously, on the AI side, things are still kind of developing, so we'll see how that comes along. In terms of where will AI probably have biggest impact, I believe it's going to be actually in the cell and gene therapy sector. So similar to these mRNA vaccines.
Right. We'll have you back in a year's time and check whether your prediction was correct in that case. Thank you very much, Roger. And then finally, Jonathan.
I think that in the coming future, we're going to see the opposite use of AI. So instead of using AI to extract valuable information and then breach people's privacy, I think because there are so many systems that are connected, we're going to see defensible AI, where we're going to build models that actually make sure that this is what's being done with our data, and governments that will support it will be highly well regarded. Yeah.
Jonathan, thank you very much indeed. And then Désirée or Birgitte, last words. We've had a fantastic discussion here, which Désirée, in her inimitable way, will be writing up. But we've had a bit of a debate here, but it's there are no easy answers in this whole area, and data is the use of these data sets is so fundamental to the effective use of artificial intelligence in healthcare that we've unpacked it from many different perspectives. So thank you very much indeed. And when is our next meeting, Désirée?
It's in May, I think, the 10th of May.
10th of May. So, and what's the subject going to be then?
We are reviewing AI strategies, initiatives of the last year.
Wow, I see. So that's going to be a 5-hour meeting then, is it? Excellent.
Especially if you invite me. Yeah.
Yeah.
Can I just say one sentence, and that is that at the Big Innovation Center with Deep Knowledge Analytics, we mapped the mobile health industry for 280 mobile health apps across lots of different fields, and we mapped them in relationship to how advanced they were AI-wise, how broad they were, how much precision they had, and of course, to what extent they incorporate expert knowledge. And you can download that from the website of Big Innovation Center, or you can click on our box called the Innovation Eye, and there you can actually see it.
Fantastic. Thank you very much indeed to all our panelists. We've had a really interesting discussion, and we obviously hope to see you back again in the future as you know, the AI and healthcare develops over a period. And particular thanks to Eldad for traveling all the way across the Mediterranean to see us. Very kind of you, Eldad. We'll have you back. Thanks very much indeed. Cheerio, everybody. Thank you. Bye-bye.